Hi, I'm Steve Hauser, current president of the American Heart Association, and I'm here today with Dr. Mark Creager, the immediate past president of the AHA. We're at the European Society of Cardiology meeting, and Mark is going to tell us a little bit about some of the late-breaking sessions on preventative strategies.
Well, thank you, Steve. It's great to be here in Rome. So there was today the first of what will be two hotline sessions on preventative strategies. And at today's session, 4 distinct trials were presented. The first was the Antarctic Trial. Now, the Antarctic Trial really was designed to ask the question, should we be doing platelet function to enable us to determine the dose of antithrombotic therapy in patients who had acute myocardial infarction and were undergoing PCI. So in this trial, there were about 970 some patients, and they were randomized to a treatment with prasugrel, 5 milligrams a day, or prasugrel, 5 milligrams per day for 14 days, and then platelet function was assessed, and the dose adjusted depending on the response to that testing. And they were followed for up to a year, and the endpoints included the usual myocardial infarction, stroke, death, as well as stent thrombosis, urgent revascularization, and bleeding. So at the end of 1 year, there were about 28% of patients in each group achieving one of these endpoints in the composite endpoint. There was no significant difference between the two groups. And really the conclusion of the study is that it's probably not necessarily to do platelet function to determine the dose of the antithrombotic therapy, in this case, prasugrel. So it's an informative study and should make a difference as we consider how to take care of these patients and in determining their dose of antithrombotic therapy moving forward.
Okay, Mark, let's hear about the next one.
All right, so Steve, the next one was probably the most impactful trial to be presented today. And this is called the Nijkamp Trial. And what this was a study looking at the efficacy of N-acetylcysteine plus nitroglycerin versus nitroglycerin alone in patients with acute ST segment elevation myocardial infarction, and determining the effect of treatment on myocardial infarct size. And they used cardiac magnetic resonance imaging both 1 week and 3 months after the presentation to examine this endpoint. The rationale for this trial is actually an interesting and important one. N-acetylcysteine is thought to be a scavenger for oxidant radicals, and it was thought that by doing so, one might preserve myocardial function directly or potentiate the effect of intravenous nitroglycerin. So the endpoint, as I mentioned, was the myocardial infarct size. The secondary endpoint was myocardial salvage. And as it turned out, the group that received both N-acetylcysteine and intravenous nitroglycerin versus nitroglycerin alone did have a 30% reduction in myocardial infarct size. Now, it's a small study, but it's a positive study and clearly very interesting, and raises the possibility that this adjunctive therapy may be beneficial. I think additional science is needed, more research needs to be done. It's an intriguing and important observation.
Thank you, Mark. So let's go on and talk about the third one.
So the third trial is called the SAVE trial. SAVE is a particular acronym for this trial, and it really was a study to look at the efficacy of CPAP treatment in patients who had either coronary disease or cerebral vascular disease. And clearly there's been a lot of promising preliminary studies that would suggest that CPAP may be effective in reducing the risk of adverse cardiovascular or cerebral vascular events in this population. So there were over 2,700 patients in this trial that were randomized to CPAP each night or not receiving CPAP. And CPAP did actually reduce, as would be expected, the frequency of apnea or hypopnea at night. And patients felt less tired during the day, outcomes you would expect. So at the end of this trial, which averaged about 3.7 years in duration, there was really no difference between the two groups in a large composite of both cardiovascular and cerebral vascular events. So I would say the bottom line is this: CPAP helps people sleep better, they feel less tired, But if we're looking at a particular endpoint in the cardiovascular or cerebrovascular sphere, that was not realized by the addition of CPAP to these patients.
Thank you, Mark. Let's hear about the fourth one.
So the next trial was the Nippon Trial. It took place in Japan, and it asked the question, does shorter duration of dual antiplatelet therapy, is that non-inferior to longer duration dual antiplatelet therapy in patients undergoing percutaneous coronary intervention with a bioabsorbable stent? So of the 3,700 or more patients that entered this trial, they actually analyzed 2,700 patients at the 18-month follow-up period. And comparing the two groups, those getting only 6 months of dual antiplatelet therapy to those getting 18 months of dual antiplatelet therapy, the difference was non-inferior. So I guess we could say comparable in terms of the endpoints, the cardiovascular endpoints plus bleeding. So interesting study. They didn't quite examine the total amount of patients they had enrolled at the beginning, so one might question the statistical power, but at least these results are suggestive that the difference between shorter duration therapy and longer duration therapy is non-inferior. And this again is with the bioabsorbable stent, so it's possible that with devices such as this, we may be able to get by with shorter dual antiplatelet therapy duration.
So thank you, Mark, so much for those great summaries. Some negative trials, some positive trials, but all interesting trials. So we're looking forward to more information over the next few days at ESC.
Well, thank you, Steve.